Does that mean Chris has to repeat everything?
Yeah, if you could just go over the last 30 minutes there, Chris.
It would probably be different the second time I present.
All right. Thank you again. I was going to switch now and go and start going through some of the roundtable topics that we had. I had a couple that were given to me, so we could start going through some of those. And then if anybody else has any additional topics that they would like to cover, certainly feel free to jump with those. First one though, Sarah,
hey, Brian, there's a couple of people who haven't been on before. Did you want them to introduce themselves, or?
Oh, yeah, I was going to have Sarah introduce herself. Was there anybody else who was new to this one? All right. Well, Sarah, did you want to go ahead and ask your question, but then do an introduction to you and your organization as well?
Sure. I didn't have another question.
Oh, sorry. I thought you had asked something about optimization ideas for M pages.
Oh, okay. Well,
if you didn't,
I'm certainly happy
form from you. You don't have to go over that. Pulled from you.
Happy to discuss it. I wasn't aware that that I had a topic. I just saw it on my calendar and I thought this looked interesting because I hadn't seen it before, and some folks from my organization had been talking about the innovations piece that they had attended last week. So
Okay.
I hop on and see, because the gentleman that handles the ambulatory side for us said that he'd been on a call. So I thought, well, maybe this would be what I was looking for. So I'm happy to discuss anything else, but I wasn't aware that I was meeting with you about anything. Okay.
Oh, no. No, I was not putting you on the spot. I thought that was a question of something you just wanted to talk about with the group, but we don't have to do that. I wasn't looking for any presentations either.
Okay. Sorry, go ahead.
Oh, no, go ahead.
My name is Sarah Leiter-Keister. I'm an internist hospitalist by background clinically, and have been involved with a number of implementations as the CMIO in Port Huron at our McLaren Port Huron site for the last 10 years. And then 2.5 years ago, was asked to be the one McLaren physician lead for our Cerner rollout at the 13 hospitals and growing. So I handle the inpatient side. We've got a Dr. Schaefer that handles the ambulatory side. And we've got an awesome team that we work with, and we're on our third hospital going up with Cerner in January. A lot of our sites are on Paragon. Some of them are on older versions of Cerner. We've got one on Meditech. So it's a journey, and we're getting there. I thought his comment about the Millennium financials too was interesting, and I'm following up. We're getting there too. We've got our head around that, I think, now too. But anyway, nice to meet you all, and thanks for inviting me.
Likewise, and thanks for joining. And sorry if I did not mean to put you on the spot there with thinking you had something you wanted to discuss. All right. Paul, you had the question as well about the risk scoring.
Yeah, this is more can you hear me? Okay, this is more just a question about how people are approaching risk scoring. We're in a number of risk contracts, like I'm sure other people are. And when we looked at particularly our Medicare ACO, the biggest opportunity was HCC recapture. The problem in Cerner is there's no indicator for HCC recapture, and what's more problematic, in my opinion, is with Cerner's innate search function, it's often hard to get the specificity you need. Because of that, we actually implemented a API from IMO, Intelligent Medical Objects, and that actually does help us with risk scoring, but we've had some technical challenges with that. We're making some progress, but it's been a slow road, and we're about a year into it. We're definitely better than we were, but it's still a problem. But I'm just curious how other people are approaching adequate capture of their patient risk. So that's more of a discussion, and I'm happy to share our experience if people are interested.
Do you have ambulatory sites, and have you done like the health maintenance tools and all that kind of stuff?
Yeah, we're pretty well. We got everything Cerner now, including RevCycle, which with a few of its challenges. We have Healthy EDW. We have information. There's an HCC module that we can look at, but it's not an actionable module. It just gives you a view of potential recaptures based on claims. So it's not really a great tool for providers. The biggest challenge is if I'm doing my annual wellness visit, say for Medicare, I'm a geriatrician by training. If I do my annual wellness visit, I look at my problem list. I won't know necessarily, except for the ones I remember, what are HCC which are the ones that need to be evaluated for HCC. And then often when we do searches for diagnosis in Cerner, we're not driving down to the best specificity we could get at. And I think that's just the nature of Cerner. I'm just curious if other people are struggling with that, how it's affect your risk scoring. We know for us it's a more than $1 million opportunity, but we're just having a hard time figuring out how to close it.
Paul, are you using workflow M pages in the problem list in the workflows?
Correct.
And you see it gets highlighted that HCCs are addressed or not addressed in the calendar year within that?
No, not on our. And Paul Snyder, keep me honest. I don't think that's available in our environment.
Certainly haven't seen it. If
Yeah.
it's available but hidden, I don't know. I wouldn't know.
Yeah, I love my Cerner friends, but sometimes they over-engineer the crap out of things. That like, what the hell are you thinking? This is one where I'm like, wow, that's great thinking. So in the problem list components in the workflow M page, there's the capabilities of displaying HCCs that have been addressed in the calendar year in any encounter. It's actually very sharp, and it shows HCC in red and bold in parentheses. It bolds the entire problem there. And then if you click that you address it this visit, it accounts for your annual evaluation assessment of that HCC. It actually, I think it works pretty well in combination with some of the other modules like health maintenance and such.
I guess we'll be doing some diving, Paul.
Yeah, I'm starting to look now. What code level are you on, by the way, Rich?
Boy, that's a good question. But we've had this for a while. I think we're on. I'll misspeak. I'm not sure.
Okay.
We took a code upgrade maybe 4 months ago, 5 months ago to whatever was GA then.
Yep.
Okay, well, maybe we have a solution. We just haven't seen it. But when we talked to Cerner, they're the ones that pushed us to IMO, which is just interesting.
Well, I think Dr. Clark, I think to your point, there's opportunities with the problem list and specificity and the secondary code mapping in addition to HCCs. And I know I feel like problem list optimization is one place where our voices have been heard with the Cerner team. And I know that there's a lot of development going on, and hopefully we'll see some of the development come to fruition later in 2021. I think they were hoping, and Jigger, I don't want to speak for you or your team, but I think the information blocking kind of pushed some things off. They were hoping to have some of those problem list enhancements, including the HCCs, ready early next year. But the latest update we got at Covenant Health was that it's going to be the end of Q2 2021. But we've kind of been on the same journey, had both struggles with capturing HCCs and some difficulty with not really case mix index on the inpatient side, but more on just severity of illness and risk of mortality documentation items, and problem list management in general. We had a separate component for HCCs that then later we went back and embedded into the problem list. So we're also seeing the HCC nomenclature within the problem list. But there are still a lot of opportunities. And Jigger, I don't know if you want to speak to any of that. I feel like some of that development work, it's my understanding, has taken a little bit longer because they want it to be able to work on the mobile platforms, and so they're having to rebuild it all.
Yeah, Mandy, you've summarized it well. Thank you.
Mm-hmm.
Dr. Clark, are you guys using Diagnosis Insights as well? This is Tiffany from Covenant.
We're looking at it. We have not implemented it yet. We have their current HCC module. They keep changing the name of it, so I never know what that is called at the moment. But we have this static view that's driven by the Health EDW that shows potential HCC opportunities. But the Diagnosis Insight is the next level up, and we're trying to load that in a non-production domain right now.
Yeah, that's definitely been a help for us. I think we went live, if memory serves me correctly, like in August of this year. And that has definitely been a win for our providers because it at least streamlines it a little bit better and, kind of just puts it in their face and allows them the ability to order right from there. So I think that might help you as well.
Yep. Well, thanks.
Paul, anything else that you wanted to discuss, either
No,
around risk scoring or just other questions?
No, that's just something that we've been struggling with. I was just curious, and it sounds like there's potentially some information for us to look at. So thanks.
Very great. Yeah, bring it back in 2 months and let us know.
So it looks like Chris has cut and pasted a screenshot into the chat, but also others in the chat are asking if they can get information on the HCC component in the M pages in the problem list. If you could find us a link, Jigger, and we could share it, that'd be great.
Mm-hmm.
Looking as we speak, Patty.
I thought you were.
Thank you. All right. Next item I had was around PCP capture. Christy, I'm not sure if you wanted to talk about that right now, or looks like Steve, you're on as well.
It's Christy. If Steve is on, he may want to pose the question. If he's not on, I'm happy to.
Okay, I thought he was on. Maybe he had to drop. Yeah.
Okay.
If you want to go ahead.
Sure. So this is a question probably philosophically for everybody, but especially folks who are not on Cerner's rev cycle. We are really struggling with capturing a high volume of PCPs when patients come in. And I think that the problem is further exacerbated with a third-party system. We happen to be on STAR. But every time there's an update to the patient in STAR and new messages come over, sometimes that information can get overwritten. And so we are struggling with really low percentages for capturing PCPs, which is a problem on one hand for providers and trying to disseminate information, but it's also a problem from a regulatory standpoint that we're not meeting our metrics. And was just curious if anybody had figured out, especially if you're not on Cerner's rev cycle, a good process for capturing this information and keeping this information.
Hey, this is Tiffany Cross with Covenant Health, and we also have STAR. And I apologize, I didn't catch the name of the person who was speaking.
Okay, I'm sorry. It's Christy Wright from Northside.
Oh, hey, Christy. Hey, we need to connect because we actually had a customization that Marcia Keck's team worked with Allscripts on, so that we could get this where it would change, like if someone changed the PCP, it would change it everywhere so you don't have conflicts. So why don't you reach out to me and we'll get you connected, or you may, I think you may already have Marcia's info, but we can definitely help you with what we did.
Oh, that would be wonderful. Thank you so much.
Yeah, sure.
Thanks, Tiffany. All right. I put one on here just because I've heard from a couple different hospitals about some of the work that they're putting in around with the new COVID vaccine coming out, some of the documentation preparedness that sites are having to put in place. Specifically here in North Carolina, there's some additional reports and requests that need to go in for sending into the CDC, but also sending into the state. So it's creating additional work for them to go and build that out. And then also the documentation of any adverse events. So they're working on trying to get that built out. I just wanted to throw that out to the group and see if other hospitals are having to do anything like that as well, or if there's any knowledge sharing that we could do around some of the new documentation that may come out with that COVID vaccine.
Similar requirements in the state of Tennessee, and the biggest challenge is making a plan for the employees who are the in phase 1 of receiving the vaccine, because we have to keep those records separate from our clinical records. So yeah, we're getting close to having a plan together.
Great. Thank you. Really just wanted to have an open discussion as well. Does anybody else have any questions or comments or anything that they want to talk about in more detail with this group?
I have a question going back to the vaccination. Is anyone implementing the mass vaccination build?
Yeah,
Or
the
evaluating.
recommended build.
Correct.
This is Mandy Hall for Covenant Health. We're still just in discovery mode. That'll take us too long to have that ready for our employees. So that's not what we'll do for round 1 of employee vaccines, but also trying to get prepared for our patients. So we're just in discovery mode right now and don't really have a final answer.
So we're in the process of doing it at Penn State Health. Took it into a non-prod domain about a week ago, working through all the registration scheduling difficulties. We've actually gotten into a very fun, interesting, scary discussion about vaccine. And is this first wave of vaccinations really employee health function, or is it a clinical function that happens to be given to employees first? And so I've advocated very much that we're in a pandemic, and we want to be able to immunize all patients in our community. It just happens to be that the first people getting immunized are patients of Penn State Health and other first responders. So I'm not sure that argument's going to fly, but I tell you, if it does, it makes the use of the mass vaccination module very easy. If it doesn't, it makes the use of that tool nearly impossible.
Yeah, this is Grace Wu at Murray Regional. Our analysts just started delving into building the mass vaccination pieces, and I think have encountered some issues as well. I think like most places, we're starting out with employees, and so I'd be interested to hear from Dr. Halford what you guys are going to be doing on your end for that. So I think we are also as well in discovery mode and kind of spinning our wheels a little bit too.
I don't care to expand a little bit more, Grace. We have an internally built system where we document flu vaccines for scanning the employee's ID badge and then scanning the immunization that's being given, and we're trying to use that same functionality to build out everything for COVID and then meet the specs of the HL7 interface to get that on to our HIE that will then pass us.
Thank you.
Yeah, because we don't really have an employee health. We don't use Cerner for employee health. We don't have an employee health module. Most of our employee health is paper at the moment. So.
Yeah, ours is too. I think they use Cerner for certain components, but at least the last time I went to employee health, most of it was on paper as well. So you're scanning the badge, scanning the barcode for the flu vaccine, and then it interfaces to push it into state reporting.
Correct. And the biggest thing was that they just had to go through the spec file very much in detail to get the interface to meet the regulatory requirements. Because Chris, I like your idea, and conceptually I agree with that. All of these are patients, but I don't think we're able to necessarily get past the legal regulatory aspects of splitting the employee record from the patient record at this point.
Yeah, it's a philosophical discussion. There's no technical issue. It's purely a philosophy. And actually, our legal risk and compliance folks said, make a decision. If you declare this as a patient provision of care for anybody in your region, great. Want to prioritize people who happen to work for your organization, who would be naturally the 1A and 1B folks, great. It saves a lot of hassle. Hopefully next month I'll be able to tell you we were successfully able to lobby to make that happen.
And Chris, that actually fits the fact that this cannot be a mandated vaccine for employee health.
That's correct.
So, I mean, it is more of a, a decision by an individual whether they want to receive this treatment. It's different than, a mandatory flu vaccine that you may have as an institution.
That's the argument we used.
I like it. We'll use it. But thanks.
Anything else people want to talk about in the open discussion?
I have a 2 o'clock, Brian, so I'm going to have to drop off.
All right, no problem. I don't know, we might lose some people here too. Appreciate everybody. If you do have to drop, thank you. Otherwise, Jigger, I was going to turn it over to you. I know you brought some takeaways from the last roundtable that we had, so I wanted to give the floor to you to be able to talk about some of those.
Yep. Thanks, Brian, and thanks, everybody. Based on the last conversation in October, 2 big topics came out of that I said I would follow up on. The first was around there's some ambulatory organizer scheduling workflows and orders to scheduling, where it was one conversation. And then the second was around intake and output, and specifically API and making available via FHIR or others some of that INO information. So on the ambulatory organizer, the question was being able to see a surgeon's schedule in line with their clinic schedule. Now, the ambulatory organizer has the capability to be shown by resource. In that resource, it should be common between SurgeonNet and the ambulatory, and should appear on the ambulatory organizer so they can have a collated schedule between the two. So I know there were some fin implications that were going on from didn't follow that entirely, but that may have something there. So that should be able to be fixed. Scheduling work queues. I did discover there are some unique CCL scripts that allow for configuration of the scheduling work queues to be able to allow for more granularity in the workflow for individual scheduling resources. So that would be to say, and I think Tiffany, you brought the question was around, you can only see the facility stuff, right? There are some scripts out there that can be localized to help find some granularity there. The orders to scheduling is an ongoing workflow difficulty pretty much everywhere. It's a hard workflow in general. There's so many nuances to it. So I don't have any great follow-ups on that one, but I'll keep digging to find out if there's any more specifics there. Secondarily, the intake and output. I got with our solution strategy teams and trying to understand what the roadmap was for intake and output. And I regret to say there's not much there, to be honest with you. Now, the fire capability therein is limited, as was discussed, because we were talking about integration with well sheet or those sorts of things. The bigger problem there is right now, the observations from a Cerner Millennium perspective holistically, which is pretty much the entire clinical events table, is not mapped to observations from a fire capability. That work is not insignificant from a coding perspective and is ongoing from a evaluation perspective. One nugget of information that came out of that is the Veterans Administration is keenly interested in having Cerner map the entire thing. And the one thing they have the capability, I know from personal experiences, they have the capability through government contracting to pay us for it, which is advantageous to everybody because then it becomes part of the code stream. That's still in discussion with the VA. Maybe we'll get some relief from VA dedicating some dollars to mapping some observations. Intake and output may be one of those that's included. So to follow up on the conversation around well sheet and intake and output, I regret to inform you there's not a whole lot there right now, but that there's a glimmer of hope with the VA and potentially pushing Cerner intellectual property to do more of that. Those are the main follow-ups I had, and I'll stop and take any questions. And I do have a link I'll be providing here as well around Cerner's approach to fire enablement and what we're doing there. If you don't have it as a resource, it's a Cerner wiki, so you should be able to review it. If you have more questions, please, you can follow up with me. The link should be able to help you also some of the things that are fire enabled from a vital signs perspective at a minimum.
Great. I appreciate you going and pulling all that together for us and doing that homework there. Jigger, I think that's really great that you've been able to go and pull some of that together. So thanks again for doing that.
Happy to help.
I did want to talk a little bit more administrative about our roundtable planning for 2021. So right now we meet every 2 months, and every other meeting is usually an innovation session like what we had with Chris today. So I was planning on keeping a format like that, which means our next session would be in February, and then our next innovation/open discussion would be in April. Is everybody okay with the cadence that we have now, meeting every other month, or would they like to see something different? The other question I have is around the time that we meet. I know this kind of sits right in the middle of the entire week, so I think we're getting great participation on this, but I just wanted to poll this group as well to think or ask if you think early in the day, like a 7 a.m. type meeting or an 8 a.m. meeting would be better, or late in the afternoon, or has this kind of been carved out for you to be able to meet it?
Brian, it's Christy. I think the cadence is good. Just my opinion.
Great.
can be pretty flexible on the time, but what I worry about with, early in the morning is it probably competes with a lot of other standing meetings at organizations where you need a lot of physician involvement. But I can certainly be flexible, so would not want to speak too loudly on that topic, but I like the cadence.
Okay. The CMIO group, the nursing group, they decided they wanted to meet at 7 a.m. So I don't know if we wanted to do something like that, but I would much rather do it right here in the middle of the day than waking up super early like that for that meeting. Perfect. And then I also just wanted to make sure that everybody's good with sort of our formatting and bringing forward some of these innovations, having sort of a question and answer section as well. I want to make sure that this is still valuable to you, that you're seeing and getting out of it what you need for the hour that you're joining. So if there's other topics or a different way that you want to go and take this, let us know, and we can go and talk about that, or shift how we're just having these meetings to make sure that you're finding it valuable and you're taking something away from it at the end of every session that we have. So if there's any feedback, would love to get that as well, so we can make sure these are valuable for you. The last thing though that I had was, we are putting all of this information out on our website. So if you have missed a meeting or you want to go and find that information, you can get these recordings out there. We've got all the minutes, and there's also the presentations, or like what Jigger has sent. We'll go and put those links out there as well. So we do collect all that. So if you need to go find it, we have it there. One of the things that we're working on filling out though is a information grid on everybody's organizations. So as you're going through and you're wondering, okay, who else has the oncology module implemented? We're starting to document those in there by site. That way you can go use that for information. And if you need to reach out to them, those other sites individually, you can, or you can bring it forward to this meeting. You can at least see who else is running similar code as you or has the same applications as you. So I will send that spreadsheet out with the meeting minutes when we have that go out, but just wanted to let you know that that is something we're trying to collect, again, to give you more information and make these meetings more valuable to you.
Brian, I know you did not start the recording at the very beginning. Is it possible to get the slide deck on the governance presentation?
Yeah, looks like Chris had to drop, but I'll see if he can go ahead and send that along to us, and we'll make sure that that goes out with everything and then is posted to the website as well.
Okay, thank you.
Yep. All right. Does anybody else have anything they wanted to talk about?
You mentioned the M pages. Did you have anything specific to speak to about that piece? I mean, we've got a lot of, we just need, the build is bad when I dig into it, right? So
yeah.
We've got a lot of things that we know how to do that we need to do to make it consistent. But since you mentioned it earlier, was there something else about that you'd?
Well, honestly, I think I saw a web form submission that you did to get onto this roundtable, I think, unless somebody did it on your behalf, but it had your name and then it had in-page optimization on it. So I don't know how that came about. Somebody may have submitted it on your behalf, but that's all I had from it. So I just put it on there.
Okay, gotcha. Thank you.
Yeah. Yep.
I want to thank everybody on the call. This was super valuable to me. The HCC coding question goes to another hat that I wear that would be very helpful for that piece. So thank you.
Great. Well, If there are no other questions, I'll thank everybody for your time today, your participation. Again, I think it was another good meeting that we had. I'll go ahead and give you back about 25 minutes or so, and wish everybody a happy holidays as well. Thanks, everybody. Bye.
Thanks, guys. Thanks. Bye.